A very good evening, South Africa time, to Joy and the Lawn family, distinguished guests, including our Dean, Associate Professor Lionel Green Thompson, Professor Linda Gale Becker, Professor Robin Wood, colleagues, students, friends, and family, and those who are joining online, and also those who will watch this recording subsequently. My name is Digby Warner, and it is my great pleasure as the Professorial Director of the Institute of Infectious Disease and Molecular Medicine to welcome you this afternoon to our institute, which is located on the Faculty of Health Sciences campus of the University of Cape Town, which for approximately 7 years provided an academic home for Professor Steve Lawn. For that reason, we in the IDM take very seriously the honor accorded this afternoon of serving as co-hosts of this important event. So that's not moving. So the program is up on the screen now, but I'm going to just provide a brief introduction and accomplish a couple of, I think, important tasks. The first one is to say that memorials are both somber and also an opportunity to celebrate the lives and legacies of those who have made a lasting impact. And that is especially true in the case of Professor Steve Lawn, who we are honoring this evening in this latest edition of the annual Steve Lawn Memorial Lecture, as well as in honoring the latest awardee of the TB HIV Research Leadership Prize, which is named in his honor. This event is made possible by the Steve Lawn Memorial Fund, and I think that some additional details will be provided later. But basically, the two major components of which are the lecture itself and the Leadership Prize. The lecture is a partnership between the University of Cape Town and the London School of Hygiene and Tropical Medicine, and we'll learn later that next year's event will be hosted at our partner site. And the TB HIV Leadership Prize is presented by the International Union of Tuberculosis and Lung Disease, and it includes a profile in Lancet of the awardee, and that was published recently. And I'll lift out some highlights from that. So when we think about Stephen Lawn, I think immediately of someone who combined scholarship, humanity, and activism. He was a multi-award winner as a student, both undergraduate and postgraduate student. And then for those of us in the TB research space, he was always and is always held up as an example of someone who was absolutely prodigious while remaining erudite and impactful. So he published well over 200 articles, which I think have been cited more than 30,000 times, and garnered an H-index of over 90. So for those in the academic space, these are all very impressive and in some cases even breathtaking metrics. From my perspective as IDM director, it's worth noting that he was an IDM member for 7 years, and so we consider him a key part of our firmament. But perhaps, I think more tellingly, when I went back and looked at several of the obituaries which were written in 2016, they pulled out this combination of humanity and scholarship. So I'm going to quote here one from Annelies van Rie and Ted Cohen, who commented on his trailblazing work on improving the diagnosis of HIV-associated TB, and particularly pointed to his commitment to the prevention of hundreds of thousands of HIV-associated TB deaths and the use of his position to challenge the lack of urgency in the global response to that ongoing crisis. They also then concluded, and this is something which really left a mark on me, was that Steve's work and tenacity serves as a template for how we can advance both science and policy in support of a brighter future. And that's actually an aspiration to which we all hold very highly within the context of the Institute. In a parallel piece, Anthony Harries and Linda Gale Becker commented that Steve would be remembered not only for his outstanding science and contributions to health, and especially HIV-associated TB in Africa, but for his many other qualities and talents, his friendship, his humanity, and his wonderful sense of humor. And I think for those colleagues in the audience and online who knew Steve particularly well, these comments will resonate very strongly. On a personal note, I grew up in the late 70s and 80s on a diet of movies and television shows, in which at some point it always seemed that people would descend into the bowels of the earth to discover how the world was actually being run. And while that may sound like a sinister analogy, it's one that came to me the other day when I recalled going downstairs into the bowels of Bernabite North as an early a recent recruit here at UCT to find Steve and Robin Wood in close discussion around tuberculosis and HIV. And the thing that I remember mostly about it, because it's still a feeling that I have when I think back to those days, was it felt like stumbling on people who have this very intimate and insightful knowledge which transcends the everyday. They understand the world and that systems and processes governing daily life, and particularly in the case of infectious diseases, those which we are required to suffer with, that does need not be the case, and that there are better solutions to it. So I always felt like going into Robin and Stephen's sort of sphere, that one was encountering truth. And so it was with great envy, actually, that I would observe some of their interactions, and I personally have really valued being able to continue my interactions with Robin more recently. Not that our partnership has been nearly as productive, I don't think, in terms of publications. A key component of tonight is to acknowledge the latest awardee of the Stephen Lawrence TB HIV Research Leadership Prize, and so this is for 2023, and we're very pleased to have the prize winner, Dr. Andrew Kirchhoff, here this evening to give us an address. So Dr. Kirchhoff is a physician scientist and an assistant professor of medicine in the Division of HIV Infectious Diseases and Global Medicine at Zuckerberg San Francisco General Hospital. He is also an associate program director for curriculum for the UCSF Implementation Science Training Program, and he serves as director of the UCF CFAR Implementation Science Interest Group. I was interested to see in his education that he started off with a BA in music in 2008, and then quickly transitioned into infectious disease space, obtaining an MSc in 2010 in the control of infectious diseases, an MD from George Washington University in 2015, a PhD from in epidemiology from the University of Amsterdam in 2016, before going on to complete residency and fellowship programs in infectious disease at the University of California, San Francisco. Andrew's interests, which are listed on his personal site and which are also covered to a certain degree in the biography which accompanies this award in Lancet, are primarily on evaluating novel tests and strategies to improve the diagnosis of TB in sub-Saharan Africa, with a focus on low-cost point-of-care tools. And secondly, in applying implementation science methods to improve individual and population outcomes through the development, implementation, and evaluation of equity-focused, effective, scalable, and sustainable TB, HIV, and COVID-19 care engagement strategies in the United States and Zambia. I think that was a very complicated description of research. I think it's really lifted out nicely in the Lancet profile when he speaks about two really key components to his work. The one being preference research, which aims to bring the voice of affected stakeholders into the design of new tools or strategies, and thereby increasing the chances of them being used and being effective. And then the second component is implementation science, where he notes that we spend billions of dollars on developing new technologies, and then only a few million on working out how they'll reach the people who really need them. And further notes that this inequity often means that the people most likely to benefit from a new technology are least likely to get it. The final comment in the Lancet profile is that, as with Steve Lawn, Kirchhoff's commitment to his work is as much a health equity as a scientific imperative. And while his work in Africa and San Francisco is very different, he notes that wherever you work, you see inequities in health. You see opportunities that need to be addressed, and I see myself staying in tuberculosis as long as it's a threat. I think there are many of us in this room working to try to shorten the duration of that threat, but nevertheless, it's very pleasing to have you in the field and a worthy recipient of the HIV Research Leadership Prize. Before I hand over, I realized one thing that Linda Gale did tell me to do, which I haven't done, is to acknowledge that there are previous award winners of this prize, so dating back into 2017 with Dr. Leo Martinez. And there's several faces and names up here who have really made huge contributions subsequent to winning these awards. And so I'll move all the way through to our current prize winner to give his address.
Wonderful. Thank you so much, Dr. Warner, for that very kind introduction, to which I am not accustomed, but I am grateful for it. So standing here at UCT, at the very place where my journey in research in public health began under Steve's mentorship almost 15 years ago, and to be recognized with the Stephen Lawn TB HIV Research Prize is incredibly humbling. Words fail to capture the depth of my gratitude and the profound sense of purpose that this honor instills. And I extend my deepest appreciation to the Memorial Prize Steering Group, Dr. Joy Alon, the Union, the LSHTM TB Center, and the Desmond Tutu Health Foundation for your faith in my work and entrusting me with this prestigious award. It's really a distinct honor to be listed among the many esteemed TB HIV researchers who have preceded me in this award, and it feels particularly meaningful to celebrate this during the 20th anniversary of the Desmond Tutu Health Foundation, an organization where I proudly was a research fellow for several years. So to have counted Steve as my mentor, collaborator, and friend for over half a decade is a privilege I don't take lightly. And our paths first crossed, as mentioned, during my time at LSHTM while doing my master's, where my growing interest in TB research inevitably led me to Steve's door. And despite my lack of publications and an unconventional background in music, Steve saw potential in me, and with a kind of professional generosity that is quite rare, he offered not just a chance, but continuous guidance and support over several years, and really is his mentorship and belief in me that have been a cornerstone of my career, and one that has taken a trajectory that I really could have never envisioned without his guidance and his influence. And so anyone who had the pleasure of knowing Steve can really attest to his remarkable generosity of time, and I'm so fortunate to have a wealth of extremely fond memories, from spirited email discussions across many time zones to excitement over potential implications and next steps suggested by new data analyses, and the more personal, reflective conversations about life over many sandwiches of casual lunch, whether it was at the IDM cafeteria or on London's cozy Store Street. And these memories are really embodied in I just want to share a couple photographs, but this is one alongside Steve and Dr. Ankur Gupta-Wright, another one of Steve's mentees who's also a highly accomplished and brilliant TB physician scientist. And yet, amidst these many fond memories, one in particular stands out, which is Steve, with Joy's support, being able to attend my PhD ceremony in Amsterdam, despite his formidable health challenges. And this, for me, was really the epitome of his dedication. And I'll just say, here we are with Dr. Frank Koblenz, my PhD co-advisor, and this profound gesture of his mentorship and commitment is a moment that I will forever carry with me. And so with Steve's scientific contributions in the fight against TB and HIV, they're widely recognized, and as you've heard, they continue to influence researchers globally and inspire them. It was his character that truly set him apart. His relentless passion and drive to combat two deadly infectious diseases that cause needless suffering amongst the most vulnerable was matched only by his exceptional humanity and spirit. With his ability to balance an intense professional commitment and scientific productivity with a rich personal life, I think myself, like many others, questioned how he managed to do it all. His commitment to prioritizing his family, his commitment to his faith, and his commitment to being an avid runner, which somehow he impressively took up in his 40s. To me, Steve wasn't just a mentor and a scientific hero, he was the personification of a life well lived, constantly inspiring me to not only pursue excellence in my own work, but also find harmony in my personal life. Building on and inspired by the research I conducted with Steve that aimed to improve TB diagnosis, especially in people living with HIV, my work now applies implementation sciences, as you heard, to design and implement people-centered strategies to improve diagnosis and care engagement in Zambia with the aim of not just improving population level outcomes, but also outcomes that are meaningful to individuals. In what Steve affectionately termed research, I conduct this work in partnership with my inspiring collaborator, Dr. Manda Moyeta at the Center for Infectious Diseases Research in Zambia. And in particular, as you've heard, I've become very passionate about the potential of preference research studies, such as discrete choice experiments, to identify and prioritize the needs and wants of affected persons and communities and bring their voices into the research community. And by more broadly adopting these methods and operationalizing their findings to new interventions and strategies, I'm quite convinced that these may provide one approach for helping to bridge the gap and reach and engage the millions of people who are still being missed and left behind by current TB services. So in conclusion, this award honoring Steve's legacy is not only a profound honor, but also a profound call to action. As we observe World TB Day this year, I reflect on our advancements in the fight against TB, including shorter prevention and treatment regimens, improved diagnostics, and the prospect of a new vaccine for adult and adolescents that is just on the horizon. And I'm excited to announce that I just read as of an hour ago that the first M72 trial participants were given their first doses of vaccine in Johannesburg just a few hours ago, which is a huge accomplishment and brings a lot of excitement. But with 10.6 million people contracting TB annually, 1.3 million losing their lives each year, and the tens of millions of survivors suffering TB's enduring negative consequences, I think it's fair to say that our work is far from over. So faced with such sobering realities, this award reinforces my resolve, and it motivates me to devote my efforts and double down to realizing a world free from the devastating impacts of TB and HIV, and ensuring the benefits of our collective scientific progress are equitably reaching all affected individuals and communities who may benefit. And with that, I will say thank you so much to everyone.
Thank you so much for that address, Andrew. And I think just to mention that it is World TB Day this Sunday, and actually coordinating this event in a very busy week of TB Day recognition events happening within the Institute. So there's a big open day tomorrow, and I hope that some of you will have noticed the banner up at the top of the building, which I think is a small cry for investment in TB Day, in global TB efforts. I'm now going to hand over to Professor Linda Gale Baker, who's going to moderate a panel discussion. Yep. You want to take me?
You could just show in previous.
Okay, sorry, and I should mention. Yeah, there we go.
Great. Well, thank you. I'm going to sit right here to do this. Sorry, great. And I'm going to sit. So, but hi, everybody. It's wonderful to see you all. And it's going to be my great honor. Do I have a clicker? Thank you. My great honor to introduce the panel and moderate this next phase of this evening. But I want to thank Digby for really putting that beautifully, and Andrew, thank you. Meant a lot, I think, to all of us. So we share many of your thoughts, but also delight that you are this year's winner. So congratulations again. It was actually on March the 24th, 1882, that Robert Koch announced that a bacterium called Mycobacterium tuberculosis was the responsible agent for a disease that caused 1 in 7 people's death in the United States and Europe at that time. In 2022, 1.3 million people died of TB, of which 167,000 were those living with HIV. Most of those people do not live in the United States or Europe anymore, but they do exist in just about every other part of the world. And 10.6 million people became sick with TB disease in the year of 22, and 2 out of 5 people with multi-drug resistant TB were able to access treatment, meaning that 3 out of 5 did not. And so certainly many reasons to have a call to action. I do want to acknowledge Kaylee Pence, just to the left of us, who is going to be recording graphically some of the highlights and insights that have already come forth, but will be coming from the panel this evening. So, do spare a glance to the right every now and then, but we will be able to digitize this artwork by the end of today. And I do want to say a big hello also to our friends at the London School and all around the world for joining us today. It's a real pleasure. Thank you for those of you who've braved coming in today and being with us in person. I know the panel particularly appreciate that. Where do I point? I wonder. I don't think this works very well. Okay. I can stand there. Let me stand there briefly. Yeah. Okay, let me stand here briefly. No. Oh, did it work now? Oh, okay. All right. Well, here we go. So the comment I really wanted to make around this slide was work done by Sabine Hermans, Robin, and I think it was Robert Horsburgh, and published now a little bit of time ago. And the important data here is that at the time, actually, when Steve was here in Cape Town, the rate in Cape Town for that period, the years that Steve was with us, was just under 450 per 100,000 people, TB in people without HIV, and over 6,000 per 100,000 for people living with HIV. So that was the time when Steve was with us. It's not that long ago. I do therefore want to say, obviously we're overjoyed that we've seen some remarkable wins, but clearly there is still a great deal of work to be done. And the reason this year that we are moving from a single lecturer to a panel discussion follows rapidly on the footprints of this wonderful TB researcher from Canada, Madhukar Pai, who was the lecturer in 2023 in London. And Madhukar, made some profound statements around picking up this theme, Andrew, of human-centered design to improve TB care. And I think you're going to hear that throughout the panel discussion. This important few points, and I'm hoping I'm going to be able to make him.
Then, if we reverse engineer treatment and TB survivors told us what an ideal care model for them could look like, right? Human-centered design, people are doing this. We've done this. Those are all TB survivors in a workshop that we helped organize. Then when we asked them, what's your wish list? Well, this is what they told us. This is the kind of things that TB survivors are genuinely, I also invited them to write a paper entirely written by TB survivors. It's in that book on what is your dream TB clinic look like. They said things like, first treat us with some respect, right? Give us some confidentiality. Talk to us. Just talk to us. Our biggest anxiety is adverse effects. We are terrified of taking TB drugs because we get all sorts of side effects and there's nobody to tell us what is going on, right? Because the system is so alien and hostile. We don't know how to navigate this. Women had a whole bunch of issues that were telling us, we don't know who to talk to about our periods during TB treatment. Can we get pregnant during TB treatment? Can we get married while we're on TB treatment? None of these TB systems are equipped to do, right? Mental health, many of them said we are really depressed. We don't know what to do. Is there a life, a career ahead of us? All of this is simply not appearing in our current TB protocols.
And so, building on this call to hear the voices from the ground, we thought in 2024, one of the best ways to honor Steve Lawn in this year is indeed to bring a group of fantastic experts, people who have lived experiences, to the fore and actually ask them to expand on these various thoughts. So it's at this point that I am now going to call on this terrific panel. And I'm going to ask each of you to come up and take your chairs. So first of all, Mbali Gianni is social media and events facilitator from Airwaza. Nikita Basson is the ethics assistant administrator at the Faculty of Health Sciences, woohoo, at the University of Cape Town. Ingrid Skuman is the director of advocacy and strategy for TB Proof. Florence Tabela is a former Caesar Pila counselor, a close colleague of Steve Lawns from way back and a senior counselor at our Philippi Village site at the Desmond Tutu, and then Zabeli Mashleni, who is an IPC counselor at the PIC TB study in the Eastern Cape site of Desmond Tutu. So it is my great honor, really, to interact with this wonderful panel who, as I say, many have interacted with people living with TB, with HIV, and or have themselves experienced the disease, both from a hospital bed, but also from a sort of patient service point of view. So I'm going to start by really reflecting that each one of you represent the passion and the compassion as TB and HIV advocates. And I'm going to ask each of you to briefly describe what led to the roles you play and the passion you feel. So Mbali, I'm going to start with you on my left here. You've come to EWOSA via Médecins Sans Frontières, another wonderful organization that does brilliant work. Tell us a little bit about EWOSA and the work the organization does.
Thank you so much, Professor Linda. So just to give you guys a backstory of my journey and why I think being a part of EWOSA was basically the next step in my career, I believe. So working for MSF, I worked in I worked in the communication department, and we read a lot of stories of people having difficulties in accessing care. So reading stories of people in war-stricken countries, stuck in the forest, trying to get help was a push for me to continue being the voices and working on platforms that bring those voices closer to us people. So as I went along in my journey, I now work closely with HIV and TB community here in Kailicha, and it became a sort of like a one-way communication. And being a part of EWOSA, it's now a two-way. We work hand in hand with the community. We see them as our partners in bringing about the messages, bringing about what's happening on the ground. So it's not a one-way communication anymore, it's more of a two-way. And seeing their stories come to life, seeing what the young people think when it comes to infectious diseases has really amplified my journey and made it solidify it in such a way that this is where I'm supposed to be with you all.
Really beautiful. Thank you. Thank you for that. And I think we'll come back to the youth aspect, which I think is such an important component. But I'm going to turn to the other end of the panel now to Ingrid. Ingrid, your journey to where you are now has been a distressing and very dramatic one. So I wondered if you would just share how this has fueled your sense of passion.
Yeah, so TB changed my life. I was working as a dietitian in public hospital. Okay. Can I go ahead? Yeah, so TB changed my life. Now everyone knows that. I was working as a dietitian in public hospital when I got sick and I was admitted to the ICU where they diagnosed me with XDR TB. Hello? So when I was diagnosed with XDR TB, the TB medication at that time was the 2-year regimen, and it was so toxic that it caused liver failure. So I went into a full-blown coma and deteriorated so quickly that the doctor phoned my family and said, get on the next flight and come and say your goodbyes. So I'm very happy to sit here today and that I survived TB. But to be honest, during that time, I felt so overwhelmed that I wanted to give up. And I had everything. I had financial security, kindness from family and friends, lots of love, a clinical team that was excellent and always there for me. And that just made me wonder, how do we expect the majority of people in South Africa who don't even have food on the table to eat to get through this? I want all people to have high quality TB care and to have support like I did. And that's what motivated me to join TB Proof, where I now play a leadership role as Director of Advocacy and Strategy.
I think everyone here will agree with me that that certainly gives you the expert label, that you're in a position to speak from within. But I'm going to turn to you, Flora. You've been along this journey for a really long time, and well, I shouldn't emphasize it quite like that. Sorry, Florence, you've been on this journey a long time, like the rest of us. And you worked with Steve, but also your child has been involved in interacting with the health system and specifically around TB. Do you want to expand a little bit on what drives your passion?
I would say my son is the reason why I even tested for HIV, because I was pregnant with him. I was told, we are testing everybody that is, now we are testing people who are living with, who are pregnant. And at the time, they didn't even know what is HIV, how to go about it. Then when I tested positive, then it was difficult for them to explain stuff. And when I asked them where to from here, they said, that AIDS, they called it AIDS. AIDS is incurable, and you'll get sick sometime and die. Should your child be born with HIV, they won't live beyond 4.5 years. So it was just that, the information that I had. And then when he was 4.5 years, he was very sick. I didn't know then that he had TB, but at the time when he was admitted into the hospital, his lung had collapsed. And then that's when they tested him. So before I could even get the results, I remember it was on a Wednesday when I walked in from work to see him. And then a nurse came with an A4 page. Are you Luyanda's mom? I said, yes. Sign this form. The doctor wants to know if AIDS hasn't damaged his brain. But I was still to get the HIV results on Saturday. And that he had, I wasn't told it was TB. They just said, the doctor said that he had bad chest infection, and he was going to be on TB treatment for not less than 18 months. So yeah, it was like horrible, because the medication, I had to travel to King Edward Hospital from Tonga, where I stayed. And this medication, they were the only one that they had. The local clinic didn't have this medication, so it was difficult. He couldn't swallow. We would pray before he could take it, because he couldn't swallow it. He couldn't swallow anything without coughing. So with all the challenges that I heard then I wasn't a talkative somebody then. I would just keep quiet and then record it in my mind. And I wanted to have more time with my child. So that's where I'm coming from. I also came to Cape Town visiting in 1999, and it so happened that the very same child that made me go and had an HIV test made me stay in Cape Town, because a day before I could go home, then he couldn't breathe. Then I landed up into Red Cross. That's where I then met somebody that treated me so well. There was no treatment then, and when I saw I'm at third stage, I thought, because there are 4 stages then, it was my last stage. So I was treated not like a machine, but like a human being. I was given Bactrim there to take every day. I can still hear the voice of the doctor saying to me, Flora, you have to take this every day. I say every day. So, yeah, that's where I got my passion.
Beautiful. Thank you, Flora. Thank you. And I do want to say Luanda is with us today, and a marvelous, wonderful advocate and passionate activist himself. So we're grateful for that. Nikita, you also have a personal interaction with tuberculosis from a young age. So I wondered if you could just bring us, all of us, into your story.
Yes. We'll share it. So November 2009 was a tough month for me. I was very sick. After 2 months of backing and forthing to a doctor to saying, something's just not right, something's just not right, to finally going for the TB test and finding out you have TB. To medication when they say you're going to get sick, but you'll get better. You're going to feel sick, but you will feel better. 6 weeks later, still no progress after taking medication. I landed up here at Grooteske Hospital on Christmas Eve, which was 6 weeks later. I went into multiple organ failure. They said I was gone. On Boxing Day, phoned my parents to say, you have to come through. I was in an induced coma. No one thought I was going to survive, but here I am. Fast forward to a couple of months later, I land up at Brooklyn Chase because the medication just wasn't working for me until they found out I had pre-XDR TB. Stayed there for 2 long years to do my full treatment. I think being there changed me, changed how you see life. I think I had an advantage though. Coming from being at Grooteske, I was also in isolation here at UCT. I went with understanding, I went with knowledge, I went with empowerment to be there and to fight it, to survive it. Fast forward lots of years, I got a job at at the Department of Health as an intern admin. That was my entry into the health sector. Thereafter 7 years in the Department of Psychiatry, and now I'm in the Faculty of Health Sciences Ethics Office, where I get to not work with it always directly, but encounter studies TB and HIV related. So it's coming on long now.
Thank you, Nikita. And finally, Zabeli, coming to you, and your passion has grown as you've journeyed down your present employment pathway. So I wonder if you can tell us a little bit about what you do and why that fires your belly.
Okay. Is it working? Yes. Good evening, everyone. My name is Zibele Malini, and I am an IPC provider from the province of the Eastern Cape in a township there. I work in a clinic, and basically what we do is we work with TB patients who have been newly diagnosed and initiated into treatment. So what we do is, as soon as somebody has been initiated into TB treatment, we go ahead and screen them for mental health issues. We utilize the PHQ-9 to screen patients, and once they screen positive, what we then do is we enroll them and provide them with IPC. IPC is interpersonal counseling. It's a scientific intervention from the United States of America by Dr. Marina Wiseman. It's never been introduced in South Africa. I'm one of the first people to get training into IPC. And now that's what we are doing. We are providing that IPC for patients that are undergoing TB treatment. So 4 sessions, IPC consists of 4 sessions where once a person has been screened positive of symptoms of distress, we go ahead and provide them with counseling. Now the sessions are quite brief, once every week, and this is what I've been doing working in a township in the Eastern Cape clinic. And I've grown to be very passionate about it as it's been very developmental, and there's been a nice growth path in that implementation science, as I started off as an interpersonal counselor and then moved up to being a trainer. So now I've had a first cohort in January of people that we trained to lay people from communities to be able to be providers of IPC. And now I'm also a supervisor. I supervise their interactions with patients that they are dealing with. So I'm very passionate about it. It's super exciting, and it's a great implementation science intervention that deals with the mental health aspect of TB patients. Thank you so much.
Thanks, Zabeli. I'm going to go back to you, Nikita. So this part, we're going to talk a little bit about some of the challenges. And as a young adolescent, discovering that you had, multi-drug resistant TB, what were some of the major challenges that you think, or real difficulties that you felt at the time?
I think for me, I can relate to you, Ingrid. Having the family support, initially starting out being in isolation here at UCT Academic Hospital, having the professor and the nursing staff talk to you, tell you why you're here, tell you why you're in isolation, tell you what your medication is for. Of course, as an 18-year-old, I'm like, what? Why? I'm not even supposed to be here. I'm supposed to be out clubbing. It's my first year out of matric. But having that knowledge, having that understanding, I can see how it empowered me for when I had to transition to Brooklyn Chase Hospital due to medical aid. Going there, having that, knowing that, and seeing your fellow patients in the ward, and they're like, we don't know what is that. We don't know why we're taking this. We must stay behind the locked gate. We don't know why. The people say we're contagious, but so understanding, and I could see the lack of understanding. We don't take this tablet because that makes you feel like that. But I'm like, but it's gonna help you. It's, yes. Take it, go have a lie down. Have a cup of tea with it, do something. But if you're not going to take it, they're like, yeah, but friends took it and they still died. So I can say, not personally for me what I needed, but I can say the fact that you have family, you have support, you have your faith, having that communicated to the community, to the patients, it would give them more reason and understanding as to why they're taking the medication, what is the purpose of the medication, and what will it do to you. Like last year's lecture, explain to them your menstrual cycles, your pregnancy, what can happen to male, female. Because I can say that sometimes, yes, having your XDR and your MDR, you are more isolated than your TB, the normal TB. You get pushed away, locked in a corner because you are that contagious. But they don't understand why they're that contagious, because it's deadly. It's worse. So that's what I can say.
Thanks, Nikita. I'm going to turn to you, Mbali, because the work you do takes you into communities, and I'm sure you see a lot of misinformation, disinformation, and you're countering that all the time. Do you want to just weigh in on those aspects? And Nikita made a great case for providing solid information.
Yeah, so a lot of the work that Iwoza does really stems from finding out the type of information that communities have with regards to infectious diseases, but more specifically TB. So till this day, when we start our workshops, we start off by having a little session where we talk about TB basics, and you see that a lot of people in the community don't necessarily know even what causes TB. And to us, that has shown us that there is a need, a huge need for tailored and relevant information to be for communities to access. So we can't talk about TB, especially in the case of Khayelitsha, and not talk about, for instance, talk about TB prevention and not talk about the living situation of almost half of the people living in informal settlements. We can't talk about TB treatment without talking about accessing food, accessing basic needs to help patients stay under treatment. So we saw that need to provide tailored information as well as that is relevant. And that's why our organization, we came up with, we create platforms and spaces where we hear from the communities exactly what they need. We hear from the communities of their experiences when it comes to infectious diseases. And in doing so, it has somehow sparked a lot of dialogue, a lot of discussions on ways forward of what we can do better. And recently, our co-founder, Anastasia Koch, had an opportunity to show how TB treatment feels like for TB patients. And it has been so insightful to hear those voices of TB patients say how that treatment feels like when they take it, what are the side effects. So yeah, so we see the need for tailored and relevant information. We see the need for more voices to come up into these spaces and share that thoughts, that therefore making it easy for the solution to be very specific to that specific community.
So before I come to you on the sort of no-do gap that Madhu raised as well last year, I'm just going to turn to Flora for a moment. Flora, taking you all the way back to 2003 when we were starting to teach people about antiretrovirals and taking treatment. Do you want to reflect a little bit about how important it is to provide good information and empower people through knowledge?
I will say, LGB, that thank you for trusting, because what I realized was that once you are HIV positive, you become invisible. You're not important. You are pushed away from living. But you trusted us. We were not educated. But you taught us. That was not the education of the lay person. And we had HIV, but you trusted us. You didn't look down upon us. You taught us everything. I mean, even with TB, if it was started in that way, it's a pity that when TB came years back, patients were not taught, they were not made to know what is wrong with you. You couldn't even open your file then without being shouted at. But with HIV, what you did and your team was to like take us through the virus, the cycle of the virus. What happened? What's happening in our bodies? And then you moved on to the opportunistic infections that we would have, and how is that treated, how to live positively. And then the treatment, how it works, where it works, what are side effects. So like you would like know your story. And then it became so easy because we knew what was happening, and we were no longer afraid for ourselves that we were going to die. And it became like HIV. I'm not HIV, but HIV is in my blood. And what is wrong with me when I'm HIV positive is that it's only my immune system that I have to look after, and then I will live. Nothing is wrong with me. Okay, so even my son, I used to ask when I take him to the clinic, other mothers, because they would say, I've given 70% of the treatment. When the doctors say you just adherence is 70%, they will think, but I was giving my child medication. Then when I ask them why the treatment is taken this way, and then my son will try to answer for them, and he would say, to recharge. I was like, I didn't think it that way, but he knew that he has to recharge. Every 12 hours, he's recharging. So, and if that training didn't happen, I was giving him efavirenz in the morning, and he kept complaining, hey, my mind is not working. He used to put it that way. So, I mean, like, now going to the people that were very, 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 very sick, they would see us getting better. We were like, well, at that time. Now, and they were very sick. They couldn't believe we will give this, and then we'll go out to measure adherence in their homes and look after them, which I think we were the clinic at home. And then in the clinic, we were with them. So now, with that, it created that relationship that lasted longer. Even today, when did I leave the clinic? Long time ago, but I can still get calls that my partner has a baby. Can she breastfeed? I'm taking this medication now. What are the side effects? So that made us one. We get relatives that way, people that I can still go to now, 20 years down the line. It's like we're still friends, but these are the people that we're journeying with. So it made HIV stress, like it lessened that. So with TB, if again TB was started that way, where the patient themselves could be taught, this is TB. What is TB? It's airborne, you get it that way. It was gonna be so easy. People are dying still because TB won't go away if it's not treated. You will just die. Yeah.
Thanks, Flora. Thank you. So, Ingrid, in your work at TB Proof, there's the, no-do gap. So what are some of the deficiencies in terms of those steps towards actually putting policy into action, seeing the things we need to do, getting them done, etc., from a health sector point of view?
So new TB policies are excellent. We now know TB testing for close contacts, people living with HIV or with previous TB like myself, can change the landscape of TB. But a policy on paper is useless if it's not helping someone who has TB. So for example, if a national policy is being released, but at provincial level health workers aren't being trained, those services won't be offered at district level. So in a sense, civil society, our role is to work with Department of Health, to work with implementing partners, and that relationship building that you are talking about, I think that should be across sectors so that we trust each other enough to say, listen, we should respond to the community's challenges. What can you do? What will your role be to take it forward? So there's a need for better coordination and support. And I also want to agree with you that we need better communication strategies. So I used to work in a rural area, and I would drive there feeling so excited because I'm going to make a difference, and I would tell them my story as an XDR-TB survivor. After a year of doing that, the community health workers came to me. They said, Ingrid, your story is okay, but actually in this area, we like drama. Can't we do a theatre play? And then suddenly hundreds of people came to the clinic. No one was like scrolling their phone anymore like they did when I was there. And similarly now, we did focus groups in Khayelitsha about the new test and treat approach and asked them, how would you like to receive the information? And they said, okay, let's do short video clips featuring a real life story of a TB survivor. And let's just also make sure we explain terminology, that we don't run ahead with TB contacts. Like, what is a TB contact? So there isn't a one-size-fits-all approach. Communities are the experts, so we should learn from them how to communicate.
Thank you for that. And we're going to pick up on that theme in a moment. But first I'm going to ask you, Zabeli, you're in communities, you're in people's homes. There's amazing resilience. And I think that has been our, and it's one of our greatest strengths here in Africa, really. Do you want to just expand a little bit on, there are needs, there are desperate needs in communities, but you can build on that and utilize strengths in communities, just from your experience?
Okay, so indeed, there are challenges that people are facing in the community, particularly the township that I work in. There are real needs and challenges that they are facing. Some of these challenges, it's a challenge of deficiency of food. They don't have food sometimes. And in order for them to be able to take their TB treatment, it's going to be very important to eat. The treatment makes them hungry. It generates an appetite. And therefore, it's going to be important for them to eat in order for the treatment to be able to work. So these are some of the challenges that they are facing. And the community that I work in, it's a poverty-stricken community. It's a community where there is little development, and therefore the IPC sessions have been able to, to unlock some of those strengths and some of those potential that they have internally in them, so that they are able to identify them, to tap onto them, and to bring them out, to nourish them, to work upon them, so that they can utilize these strengths and potential to be able to develop themselves. So one of the problem areas that IPC deals with, it's the problem of life change. A person feels distressed because their life has just recently changed. Now they are into TB treatment, and this is affecting their mental health. Now, the problem area of life change seeks to tap into people's potential, make sure that they craft them, they they purify it so that it can be able to, they are able to utilize their skills and their talents to improve their situation, particularly in the township that they live in that is underdeveloped, where they are faced with starvation, unemployment, and poverty, and lack of access to resources. So they use their, they tap into their skills and potential and their strengths so that they can make a positive contribution to themselves, to their families, and the community at large. So that's one of the strengths and one of the impactful roles that IPC has played. It's played with regards to the mental wellness and also in improving the real life situation that they are faced with.
So I think, we are hearing the theme that this is not just, sorry, Robert Koch, a mycobacterium bacteria that we have to, it really is a social condition and affects people across their whole lives. We've heard a very strong plea for better information. And so I'm going to come back to you, Mbali. Ewoza is doing really fascinating work in innovative ways to educate and bring information. Do you want to just expand on that?
Yeah, I get very passionate when I talk about the work that we do. Like I said before, the community needs tailored and relevant information, and the only way to make that possible is to be in partnership with the community itself. As Ingrid has explained, that they are the experts. They know what's happening within their own communities. So one of our programs, our core programs, is Learner Doctors, where we work with amazing kids from Ikamva Youth, grade 9, 10s, and 11s, where they go out to the community to find stories of TB survivors, to find stories of just in general as well. People want to share how these infectious diseases have impacted them. And in doing so, they then come back to our working space where they put all those stories together in creating documentaries. And I just want to highlight and emphasize that these documentaries are their narrative. They have the entire editorial control, so they tell their stories how they want to. So it really makes it more authentic. It makes it more genuine. And what I also like about our program is that we're not only exposing the community to what's happening within the community, but also there's some exposure with what's happening within the biomedical community. So we're bridging that gap of showing young people that there's research happening, and this is how you can contribute and share your stories about how these diseases have impacted your community to help build solutions. So and I also feel like it's a whole cycle, because these workshops at UCT that we hold are facilitated by young students, postgrad students here at UCT, meaning that they also get to be exposed to the communities that their research may be based in. So it's a whole cycle that we're building here, where we're going to work towards better solutions and better outcomes in the future.
And it's a beautiful model, so congratulations to you and Anastasia again. Going back to you, Ingrid, Nikita mentioned it, and well, I think both of you did, the power of family. So I know a lot of TB Proof's work is around family-centered, differentiated care, and the importance of drawing beyond the individual, the sort of socio-ecological model. Do you want to just throw in some thoughts about that?
Yeah, when I joined TB Proof, I think we started out in 2012 as health workers and healthcare students affected by TB, but we've grown to now represent affected communities, often relying mostly on our TB survivor-led advocacy work as part of the team of clinical medicine, public health, academic research, and social science. But we now really rely on information and input from TB survivors and their families. For example, we recently did TB stigma assessments in Khayelitsha and found high levels of anticipated internal and enacted stigma. So now the next step will be to work closely with those families and the local health workers to develop a multi-level stigma intervention tool. As Abele said, there are mental health and substance use issues that need to be addressed. So yeah, we need to see more than just the medical. We need to see the person in front of us, I think.
No, that's lovely. I'm going to ask you, Nikita, to comment a little bit about that. And, I think we all feel the importance of finding new medications, shorter medications, alternative medication. I'm delighted to hear that a new vaccine trial is starting. But just everything else around TB, do you want to comment a little bit about that, having been in a hospital for 2 years and taken all that medication over a period of time?
I think my comment would be everything that comes with TB is all TB related. A point that I'm very passionate about as well, and I lived experience, and up until today, I still go for psychotherapy, looking after my mental health, because I sit back and I think, why do I still have mental health issues? Of course, as an 18-year-old, just diagnosed with pre-XDR TB, it has changed my life. And I was privileged enough to have my family visit me all the time, unlike other patients that were at Brooklyn Chest with me. I had whatever I needed, yet I still saw fellow patients pass away, sometimes more than one a day, around you. And no matter how your family is there for you every day, no matter the fact that the medication is working, the doctors are happy with your progress, your mental health is dipping on the other hand, because I have to go to sleep tonight. Am I going to wake up? The person that was laying in the same room with me passed away, and they seemed fine. So yes, Prof, I think it's the whole package. It's social, it's the community that's out there also. Sometimes I think it's not even when you have the TB, having the knowledge, it's the people that's out there that thinks the stigma of having TB, that's never had TB. What they think is also their understanding needs to change. And that's not just in our townships, it's everywhere. It's absolutely everywhere. Thank you.
Yeah. So our time is coming to an end. So I'm going to ask each one of you now to really think about the call to action. What are the 1, 2 things that you would really hope to see change, or people in this room may be able to, amplify this message going out as you are? What would you like to see change? And I'm going to start with you, Mbali.
We was a public engagement organization, so our call to action will be investment in engagement. We are a small team that's implementing high quality community and public engagement, and we need more voices, we need more organizations to be on the grounds, to engage with communities and to really bridge those two worlds of research and what's happening in community and have them come together. So we really believe the investment in public engagement needs to go further. Thank you.
Great. Well, I love that. I'm going to go to the other end again. Ingrid, you next.
Let's use what we have. We have brilliant TB policies. Let's scale up TB testing collectively. And in South Africa, TB is the leading cause of infectious death. So we need to think about, this week is we're celebrating Human Rights Day. We say people have a human right to health. We talk about the right to food, to housing. And as a dietitian, I'm baffled that we can provide people with expensive pill boxes to monitor whether they're taking medication. But we ignore evidence from India showing that nutritional support is associated with decreased mortality. Again, excellent available evidence. So I think my call to action is to let's use what we have. Let's listen to the evidence and start implementing better. Thanks.
Thanks, Ingrid. Let's go to you, Florence. Flora, sorry, Flora.
I see something that I believe support. I was helped more by support. I was supported. That is now not the people are not treated as, I will say, patients or clients. It's so, they are not happy when they go out to the clinics. So I think if they can be, people can be treated as human beings. I was like listening at the clinic, an elderly man was asking after he was seen, where do I put this folder? And then instead of him being told, put it here, no, don't put it here, put it here. It was like, your folder is too thick. Where do you use to keep the folder? I was like, the person was offended that the man is asking. Now, people are scared to go to the clinic. It's like people are no more people. And they default. You go to the clinic, you are treated badly. And then you can die. Because you know when you go to the clinic what will happen. And if we can treat each other. You know, the first time I saw the doctor at the clinic, I didn't know about HIV. I didn't know anything. I had TB. But because I was treated well, before I put the pill into my mouth, I gained. I weighed 64 kgs, big woman like me. But by the time I went to the TB clinic to start treatment, I was at 75 kgs. Simply because I was treated well. So I still go with support.
Thank you. Beautiful. Thank you. Let's go to you, Nikita. We'll give Zabeli the last word.
Sibeli, I don't doubt you're going to bring up mental health. So I'm not even going to touch on it. So to me, the one thing I want to say is two-way, tailor-made needs for good information going out, yes, into communities, but I also think we need to think of going into the TB hospitals, the facilities, your DP Marys, your Brooklyn Chase, going out so that it's a two-way. The patients know why they're taking, and the doctors, the researchers, the clinicians, they know and understand and will without a doubt know the patients will take the medication, and the patients will know exactly why they need to be taking the medication, including the bad side effects.
And Madhu said it beautifully, talk to us, simply talk to us. Zabeli.
Okay, so number one, I would say let us have mental health screening tools. That's very important for facilities to have whenever a patient is, initiated into TB treatment. Let's screen them, let's check their mental health, and if it's coming with a negative results, let's then, number two, it comes to the second point now, bring or call upon investment for training for IPC. It's very brief, it's doable, we are doing it now. We investment to have training rolled out at a mass scale, at a national level, is going to be very helpful and impactful, because once we have people in clinics, in your rural community at a clinic that is going to deal with the question of mental health for that facility, it's going to be a toolbox. It's going to be, at the clinic's at the tip of the clinic's finger, so that when a patient screens positive of mental health issues, then we have somebody ready to offer them services. So I think those are the two things. Number one, the mental health screening tools, and then number two, investment to train a whole lot of lay people, lay counselors in communities, so that they are, quickly accessible to clinics.
Thank you. And so I hope you will all join me in just, agreeing that there's a cachet of wisdom here. I'm interested, for those of us who work in the biomedical world, I have not necessarily heard that we needed, although we do, we congratulate and always champion new drugs, shorter treatments, new vaccines, but what you heard here was making use of what we already have. And it is, in the words of the Archbishop Tutu, and I will invoke that, given that this is our 20th year of proudly bearing his name, is Ubuntu. This notion of us being who we are because of others, that passion and compassion, the recognition that we should provide family-centered, differentiated care that respects the individual and really comes to them where their needs are. And, it's not to say that will kill the Mycobacterium tuberculosis, it's true, but it will enable all the other, wonderful tools that we have to come together in a way that we can overcome in extraordinary methods and ways. So I just really want to thank each one of you. You've shared your lives with us. We're so grateful for giving us into, your challenges, your work, and your, personal history. So thank you for that. And we, on behalf of everyone, just again wish you well in your work, your advocacy, your activism, and may we recognize a world without TB together sooner than we could imagine. So thank you very much indeed to all of you, and I'll hand back to Digby. Stay sitting here.
I think this microphone is working. So it now falls to me to call on Professor Joy Dawn to give a thank you. I think, we changed it.
Yeah.
I'm sure. Okay, sorry. Apologies. Then I'm changing that. It's call on our Dean, Associate Professor Lionel Green Thompson, to give us details about what's going to happen next year. Yeah.
I'm not doing next year. Yeah, okay. So it welcome, and especially to Joy Lawn for being here with us this evening. Just a really warm welcome to Cape Town, and then to Andrew Kirkhoff, the winner of the award, really for an incredible career that's just starting but already seems to have achieved so much. So in South Africa we might say halala, Andrew, halala. But I want to start with just an isiXhosa. I'm not sure how much time you prepared for me, but just I want to just say this, because as I sat here, I almost felt the creation of the kind of faculty we want to become. Sihlangana namhlanje, nasekusasa sizoqhubeka sisebenza, but sizosebenza ngempilo namandla yamadlozi. And I say that because even as I sat here today, I felt the presence of Steve Lawn, Namadlozi. He, as an ancestor from that spiritual realm that we almost always invoke as African people. Because in hearing, and I try to read, as I do every time this lecture comes up, to read the story of Steve Lawn, and how he became woven into the fabric that is this faculty, that is the people around this area, and the colleagues with whom he worked, I can't avoid this idea of ancestry. And I want to say today that as we hand over the baton to Joy Lawn and her team in the UK for the next round of this, I want to pay special tribute, Linda Gale, for the imagination to speak differently to the same story. Because you're right, TB is not a mycobacterium alone. It is a social-political event. And if we don't recognize that, as we did through the words this evening of Mbali, Ingrid, Flora, Nikita, Zibela, thank you for giving it a different voice. And thank you very much for that. So, Joy, may I ask you to join me here, as I wasn't sure if there is a baton or if there's a symbolic shaking of hands, but I want to just say, we hand over to you in the UK for the next. Thank you very much. Thank you.
Thank you. Thank you. And I, on behalf of the watch party at the London School that are watching this online, my phone is lighting up. I want to thank you for hosting here, and Digby, and really I do this on behalf of Steve, first of all. So before Steve died, he knew that we were going to be doing this lecture each year. We do it next to World TB Day, because that was what he was most passionate about, the human side that we've just heard so powerfully. And the two things, of course, he was sad to leave his family. He wasn't frightened to die. But he was sad also to leave behind communication, not the science, but the gap from policy to action. What was with humanity was what he was most passionate about. And his hope was that each year between when he died in 2016 until 2030, when we have to try to meet this target, right, that there would be some action that would be taken. And I have to say, each year it has surpassed, and you guys have surpassed again. Thank you. And he also dreamt that that leadership that we need, if we're going to close from policy to action with humanity, then we need to have leaders. And it's just such a treasure to have Andrew here, who Steve deeply valued that relationship with. And it's amazing to see that after 8 years of prizes, actually, you know, we haven't exhausted. Actually, each year it gets more competitive, which to me is exciting. You know, the leadership, this prize is not just about publishing science. It's about addressing equity and gaps across Africa for people with HIV and TB. And may we have more, and may we have more from this continent. So on behalf of Steve, I want to thank you for those two things. On behalf of his work family, so this is a partnership between UCT, the Desmond Tutu HIV Centre, the London School, also the Union for TB, and the Lancet. So Lancet will be posting this film of your voices and your call to action, and I hope people will take action on that. And I particularly just want to thank Linda Gale. You've thanked everybody else, but, you know, I just, Oprah Winfrey, eat your heart out, glamour, style, and heart. And that is truly what this is about. And I want to give a particular salute to Flora. So I know that Steve really appreciated you. And in fact, when we were here in Cape Town, there was a fundraiser. And I wonder if this could be repeated for your 20th anniversary, a fundraiser with these pictures which were part of a calendar and signed by Desmond Tutu. And Steve bought this one because he appreciated Flora. And we have that signed picture up in our house. So Flora, all of you panel, absolutely lovely, but Flora, just a special thank you to you. And this is our family just a couple of months ago. And, you know, 7 years, we still miss Steve every day, but I'm so proud of both Tim and Joe. And you know, he often talked about how the family was also people he had met in Ghana and here in South Africa and across the world. And I just want to thank all of you and to say, as I think Digby said, there's no I in research, it is we. We search, and we search together with you. nothing about you without you. We searched together. So thank you all, and may we continue to do this together. Thank you.
Remind people that there are refreshments upstairs. Thank you again, Digby, for having us in the IDM, and please join us for some refreshments upstairs, just in the cafeteria, one floor up. And again, Kaylee, thank you. We're looking forward to seeing this as a completed piece, but really beautiful. Thank you, and congratulations to you and your work. So, Kaylee.